Well, thank you, Lee, and to everybody at Pankey for this opportunity. I'm really excited about this opportunity to be able to let you all gather some more information on how anxiety and depression, sleep disorders, and pain are related. Like Lee said, I do have a little bit of a training background that I think might be interesting to you all, just so that you kind of know where this information may be coming from. I began my career as a general dentist after graduating from the Medical University of South Carolina. And after a while, I did go through the Pankey continuum. During that process, I really learned a lot about the relationship-based dentistry and that importance to know both yourself and to know your patients well, to be able to get a full grasp on how you can best treat them. Remembering that each patient is not a list of problems to fix, but a person. And that has really stuck with me over the course of my following years. I became more interested in the types of, originally the types of temporomandibular joint disorders that aren't easily managed. And I started a trail following Dr. Henry Grimion, who may be present this afternoon, and if he is, I'd like to say a hello. But I ended up going down to the LSU orofacial pain continuum and studied under his mentorship and learned some more about orofacial pain and became even more interested and wanted to learn more. I then completed a master's degree through the University of Southern California in orofacial pain and oral medicine. Since then, like Lee mentioned, I've become a diplomat of the American Board of Orofacial Pain, which is now recognized as a specialty. So I'm really excited about that as well. Currently, I am in practice with Carolina Center for Oral and Facial Surgery, doing conservative care for patients with oral and facial pain. So I don't have any financial interest in anything that I'm going to be talking about today. So, so there's no disclaimers or disclosures that I need to make there. So why don't we go ahead and get started? So first I want to, let me move this little chat bar out of the way so that I can get my, well, for some reason, there we go. My arrows weren't working for just a minute. I apologize for that. But what I'm going to talk about today, I'm going to use the broad term neurochemicals. That's just going to cover any neuropeptides, neurotransmitters, hormones, anything that's associated with the signals that the nerves are communicating with. We're going to talk about common mood disorders, the most common ones being anxiety and depression, and those are what I'm going to focus on here. And then we're also going to mention sleep and some of the structures of sleep and how sleep affects you. And we're also going to talk about pain modulation. At the end, I'm going to try to make sure that I tied all that together so that you can see how closely they all are related. And then I know that a lot of the background for many of the people that are attending would have to do with temporomandibular joint more so than other types of pain. So I'm going to kind of try to focus on how this may be related to that as well. So we're going to begin with the mood disorders, anxiety and depression. Oftentimes, these patients will come into your office. You may notice in their medical history that they're on certain medications that make you suspect anxiety or depression, but what you don't know is how active it is at this time, how much they're being affected at this time. And some patients may not be on medication and be very affected by anxiety and depression as well. So what we're going to talk about first is what you should look for. Now, there are some similarities between anxiety and depression. There are some differences. When we begin to look at anxiety, you can see the patients tend to have a restlessness, maybe fatigue. If they have more of a PTSD type of anxiety or post-traumatic stress disorder, there's going to be a lot of hypervigilance, exaggerated startle reflex. These patients may have difficulty concentrating, and some may be irritable. And then, of course, there's the physical side effects of muscle tension and sleep disturbance. Depression has some of the same types of experiences, such as irritability, loss of sleep, sleep problems. But what we notice also is a feeling of worthlessness or helplessness, hopelessness. They also have a guilt, and this guilt can be one that is, it's not because of a situation. It's not something that they should be feeling guilt for, but they still have this overwhelming feeling of guilt, of responsibility for something. And then they can have a loss of interest in their daily activities. They may become less interested to be involved in family activities or things that they used to love to do. There can be appetite changes. And then, as we mentioned before, sleep problems, loss of energy. And then, of course, in the severe cases, what we are looking out for is patients that have thoughts of suicide. So for me, the best way to bridge the gap and to start the conversation about mood disorders is a little tool. It's called the PHQ-4. It stands for the Patient Health Questionnaire. It's the 4-question evaluation for anxiety and depression. You can Google it. You can find it anywhere. And the reason I use this is not to make a diagnosis. I'm not a psychiatrist. I'm not trying to be. What I am trying to do is find out what risk factors my patients have. So it's very simple. You can either have it as part of your intake forms to have them fill out. You can ask them the simple questions. But it's basically that over the last 2 weeks, have they been having these symptoms and the amount of time they're having the symptoms, whether it's nearly every day, more than half the day, several days, or not at all. The first 2 questions are about anxiety. So their feelings of nervousness, anxiety, or being on edge. They're also not being able to stop or control worrying. The second set of questions is about depression. So it's little interest or pleasure in doing things, feeling down, depressed, or hopeless. And then you tally up the scores for this. You can do it by subset. If they have a score of more than 3 in either anxiety or depression, then that's worth a referral. That means that they're at risk. Overall, when you add them all together, the risk becomes 3 to 5 for mild to moderate, 6 to 8 for moderate, and severe is 9 to 12. And again, at this point, I would not give them a diagnosis. I would say, I see that there is a risk factor for anxiety or depression. Would you be okay with me making a referral for you to talk to someone more about this? And that's basically how I start that conversation. And then I ask them, now, do you feel, if they're already taking medication, is your medication helping? Do you have an appointment set up with your doctor? Maybe this is something that you need to be further evaluated for if it doesn't seem to be well managed. I always make it a case for the patient to know that I'm not asking these questions as a way to figure out if there's some underlying reason that they're telling me they have pain or that they have something else. I'm not looking for, a lot of patients fear that you're trying to say that it's all in their head. That's not at all what we're doing here. We're just trying to find other risk factors that they may be susceptible to. Now, I told you all that I was going to talk a lot about the neurochemicals. Again, that can be neuropeptides, neurotransmitters, hormones. But what we're looking at is the concentrations of these and how they can be different for patients, in this case for depression patients. So cortisol, which is basically the stress hormone, can be elevated in depressed patients, as well as pro-inflammatory cytokines. So we can see inflammation and the stress hormone raised. But we do see a decrease in BDNF, which is basically a neurotrophic factor that helps with nerve plasticity or remodeling. So that's decreased. 5-HT, which is also known as serotonin, which helps in maturity, decisive behaviors, calmness, that's going to be decreased. I listed norepinephrine or noradrenaline, depending on where you're from and where you were trained. They can be called different names, but it's the same thing. That is also decreased in depressed patients. This affects their alertness. Now, in a normal circadian rhythm, you'll have the highest level of norepinephrine when there's some sort of startle or alarm or something like that. And then you have the lowest level at sleep. For these patients, it's just a little bit lower than what the baseline for an average person would be. Now, GABA, you'll notice that I'm going to talk about several places today. GABA is basically going to be your calming mechanism in a healthy person. And this level is also lower here, so it's not able to calm as effectively when its levels are lower. So cortisol levels tend to be higher in the evenings and lower in the mornings. I'm sorry, I said that backwards. They're actually higher in the mornings and lower as you go into the night. At a higher level, particularly in the evenings, then there's a correlation there to depression. So those cortisol levels, that stress hormone, tends to stay more elevated even at the time when it should be decreasing to give you a chance to get better sleep. Now with anxiety, you'll notice that some of these neurochemicals are the same as the ones that you see affecting depression. This is why a lot of times those two disorders are grouped together and are treated together. But we notice that the concentrations of serotonin, of norepinephrine and noradrenaline and GABA are decreased in this. And we also see CCK, which is a cognition and behavior modulator. So that's decreased as well in anxiety. Now, if we move on to sleep disturbances, we'll see some similar things. So with wake, you're going to see acetylcholine, glutamate. Glutamate is always an excitatory chemical. Hypocretin and orexin are also going to be more wake, more excitatory. Now for sleep, that's when we need our GABA levels to be higher to calm us down. There's also several peptides that I didn't list out. Growth hormone, releasing hormone is associated with sleep, as well as prolactin. There's a separate study that mentions that decreased serotonin can also lead to insomnia. So that can be another factor. Now, cortisol levels also can affect sleep, as we mentioned earlier. The higher the cortisol level, then there can be more fragmented sleep or shortened sleep. But then it becomes a vicious cycle, because once you have that fragmented sleep, that disruption of sleep, the cortisol levels are going to be higher the next day. So then again, they'll end up being higher closer to bedtime, and so then it's going to fragment the sleep again. So this again can kind of spiral and become more and more problematic. This slide shows us the normal circadian rhythm, what we would see in a typical patient. And this is just, you'll notice that at breakfast time, there's a spike in cortisol levels. That's when you're waking up. It's time to get your day started, time to become more active, and your cortisol levels up. It starts to taper off throughout the day. You get little spikes at different meal times, but then by the time it's bedtime, it's tapered off again. And this is what changes in patients that have either sleep or depression, anxiety affecting their cortisol levels. I also wanted to go over the stages of sleep. This is a very simplified model here. And basically what you'll see is that there's the wake, and then you go into stage 1 of sleep. This is the very light sleep. You can be easily aroused at that time, easily awakened. So you're not getting very much restorative sleep here. Stage 2 is a little bit deeper sleep than stage 1, but it's still not the deep sleep that you need to be restorative. When you get down to stage 3, or stage N3, then that is when the restorative properties for your body take place. It used to be subdivided into N3 and N4. Now it's just deep sleep. It's just 3. But you should spend roughly 20 to 25% of your night in this stage of sleep. Then you kind of come out of that, and instead of going to wake, you go to REM. And with REM, you should also spend about 20 to 25% there. REM is when your body is basically paralyzed, it's not moving, but your brain is very active. This is when a lot of memory consolidation takes place. But if you imagine that if you are being disrupted from your sleep and not able to go down through those different stages of sleep, if you never get down to the N3 sleep, or you never get to REM sleep, then those restorative functions are not taking place. And you should actually, on average, it varies with different ages of the patient population, but on average, you have roughly 4 to 6 90-minute cycles that it takes you through these different stages. So we know that in addition to different sleep characteristics, there are these sleep characteristics can be when you are awakened, or if there's a sleep latency, meaning it takes you a little bit longer to fall asleep that day, or sleep efficiency is how well you're able to go to sleep and stay asleep. And sleep architecture is the ability to go through those different levels, those different stages of sleep. So those can, if you don't have the correct characteristics, then that dysregulation changes those cortisol levels. And then we also know that health and reducing stress, improving mood, all of controlling inflammation, all of that plays a role in the circadian rhythm. So one thing that a lot of the patients in the United States population this time, what we have to screen for is obstructive sleep apnea. It's a big risk factor for disruption of sleep at night. With any type of sleep problem, they can have fatigue or memory and cognitive defects. With obstructive sleep apnea, which is basically the airway is blocked while you're sleeping, oftentimes, I won't say usually, but oftentimes it's at the base of the tongue. There can be other types of problems, but that's generally the area of obstruction in the pharyngeal area. With that, you take the number of apneas, which is the cessation of breathing for a certain period of time, or the number of hypopneas, which is restricted breathing. You add those together, divide them by the number of hours, and you get the apnea-hypopnea index, which is basically how many times during an hour do you have difficulty breathing to the point that it disrupts your sleep. There's also a RERA, which is a respiratory event-related arousal. Those aren't to the point where you're breathing, where your oxygen saturation is affected, but it's enough of a disruption that your body wakes you up out of the sleep to allow you to breathe better. So these patients will also have cognitive difficulties or excessive sleepiness in the daytime. With obstructive sleep apnea, so with the patients that have the oxygen saturation change or decrease, There are other comorbidities that we also look for, such as hypertension, diabetes, dementia, obesity. They'll often wake with morning headaches. Now, some signs that people are aware of is snoring, but sometimes the people with the worst sleep apnea don't snore as much as you would think because they're not breathing, and then they'll kind of gasp for air rather than the typical snore pattern. There's also the excessive daytime sleepiness, and sometimes bruxism can be related. It's not always. We think of it more as a correlation, but it's something that we kind of want to look at the same time. There are some studies that show that it's a way to try to keep the airway open in some people. There are other studies that show that people have bruxism for other reasons, but it's something worth looking at. So when we're looking for excessive daytime sleepiness, there's a form that gives us a measurable, a comparable answer to how sleepy someone is, rather than being completely subjective. So you ask the patient how likely they are to fall asleep in the following situations. So there can be no risk all the way up to high risk. When you tabulate this, no risk is 0 points, slight risk is 1, moderate's 2, and 3 is high. You ask them all the different situations, such as sitting and reading, anywhere from that to sitting in a public place, to sitting and talking to someone, or even if they're driving a car and they fall asleep in traffic while they're stopped at a red light. When you add those up, 0 to 9 is considered within normal range. When you get to 10 to 12, that's considered borderline. In this area, if they're having other signs or symptoms of obstructive sleep apnea, or they have comorbidities, then you would definitely want to refer them for a sleep study. Now, at 13 and above, it is advised that you refer them for a sleep study as well, because there's something disrupting their sleep, whether it's obstructive sleep apnea or whether it's a sleep disorder such as narcolepsy. We don't know that yet, and that's not for us to make that decision, but it is something that we want to have evaluated. Now, the third set that we're going to talk about today are the pain patients. So first, I just want to kind of review the area that I work in is basically from the neck up. And so the main nerves that I'm focused on in my daily practice is the trigeminal nerve, which is, I'm going to bring my little cursor over here. So we have the ophthalmic branch, the maxillary branch, the mandibular branch. But you notice there's part of the jawline right here that is actually covered by part of C2. These are the cervical nerves, C2, C3, C4 down here. And while their dermatomes look like they're very distinct, in some patients that can be a little bit of, they might not follow the textbook exactly, but this is a good outline. Now, the reason I put this other graph on here is I wanted you to see that the trigeminal ganglion then sends signal back to the spinal nucleus of 5. And this is called the spinal nucleus, obviously, because it is in more of the spinal column than it is within the brain. And you're also having input from the cervical nerves within that area. So I'm going to mention in a little bit about central sensitization, and this kind of comes into play there. It's basically, it sets up how the nerves from the trigeminal nervous system can be affected or can be misinterpreted as pain within the trigeminal dermatome when it's coming from the cervical dermatome, or how even within the trigeminal system there can be a change in where the site of pain can be different than the source of pain. And that's something that we have to work through with patients as well. So I talked about sensitization. First, I'm going to I mentioned it. I'm going to give a little bit more detail now about peripheral sensitization. So this is not within the brain and spinal cord. This is in the peripheral portions of the body. But if there's an injury, what you notice is that there are metabolic byproducts and inflammatory soup. Inflammatory soup is the substance P, norepinephrine, prostaglandins, nerve growth factor, serotonin. We also have bradykinin and ATP within this inflammatory response. After that, if we remember, the afferent nerves are the nerves that come from the central nervous system to the periphery. So these nerves send signals or send substance P, calcitonin gene receptor protein, and neurokinin to the area, which also increases pain sensation. So basically, when there's a trauma to the periphery, we have inflammation and increased pain reception. And the reason for this is so that when we have an injury, we will be more guarded and we'll protect it so that we don't re-injure it as much. If it's painful, then we're not going to touch it as much. We're going to kind of give it some rest. And that's what this is for. Now, central sensitization is a little bit different. This is where we set up the patients that are going to have more of a chronic pain. There are excitatory chemicals called substance P and glutamate. When they're activated or when they're in more concentration, higher concentration, there's going to be more excitatory effect. There's going to be more of the signal. Inhibitory ones would be GABA again, norepinephrine or noradrenaline, glycine, adenosine, and then our body also can make endogenous cannabinoids and opioid peptides, which also help to suppress pain. So within our central nervous system, we can either upregulate pain or downregulate pain. And it's to help the patient to either get away from the source of pain or to be able to get to safety and suppress that pain to a level that they can manage it, is what we think the original purpose of these types of mechanisms were for. But they can get out of balance to the point that a patient can have chronic pain. We also find that in some studies, serotonin, whether it's in high or low concentration, has different effects. A very low concentration can be excitatory, but in high concentrations, it's inhibitory. So we'll see that as a modulating factor as well. Now, there's a pathway called the descending pain modulation pathway. So descending meaning it's coming from the central nervous system down to calm the pain signals, to make it less effect on the patient, so that the patient can get to safety or function without pain. Now, norepinephrine or noradrenaline seems to be key in that. Dopamine and serotonin reinforce those effects. And especially in neuropathic pain, or pain that is, that the pain itself is the disease rather than a symptom of an injury. So another point that I wanted to make is that pain itself is the leading cause of disability. It decreases the ability for patients to be able to work productively. It decreases their quality of life. It affects medical expenses. The reason being that patients will go from one provider to another trying to find somebody to help them. They'll end up in an ER trying to get help, and the expenses add up in this way. So I'm going to try to bring these things together for you. But one thing before that, I did mention opioids before. One thing that I would mention, especially with the opioid crisis, one thing that I want to make sure that people know is it's not just avoided in the long term because of its risk of addiction, it's also just not beneficial for long-term chronic pain management. Over time, and I'm not going to go into the mechanism of it, but over time, it can actually increase the pain perception that the patient has. While they have the medication, the pain level is low, but the pain level without medication is increased because of the mechanism of the opioid working. Now, opioids also decrease slow wave sleep and REM sleep, and they increase nocturnal wake time. And we've already learned that if we don't have adequate sleep, then we're not going to be able to modulate our pain as well either. And then there's also an increased risk for sleep apnea because of it being a CNS depressant. That suppression is going to keep the patient from being able to respond in such a way that they can help to keep their airways open. Even NSAIDs can be a factor in sleep latency. If you remember, sleep latency is the amount of time it takes to fall asleep. So that's something that we want to keep in mind with our patients as well. So one thing that we've noticed is that stress-induced inflammation can be tied to a number of diseases and disorders. I did highlight temporomandibular joint dysfunction because, like I said, I know there are a lot of dentists in the audience, and that would be something that you would be looking for. But also, if you notice, it's stress-induced inflammation. So even though it's stress-induced, it can exacerbate rheumatoid arthritis. It can affect chronic fatigue, fibromyalgia, osteoporosis. It doesn't have favorites. It seems like it can affect various parts of the body. I'm not going to have you try to read all of this. I'm going to try to go through it as easily as I can, but I think there was a lot of important information here. So cortisol, or the stress hormone, normally binds to the glucocorticoid receptor. And when it does that properly, it's anti-inflammatory. If you have too much cortisol for too long, it starts to work almost like a diabetic patient that's insulin resistant. You still have the cortisol, but it's not binding to the glucocorticoid receptor anymore. It starts to instead bind to a mineralocorticoid receptor. Now, when that happens, it becomes pro-inflammatory. So that's why these people with high cortisol levels, which normally helps with inflammation, are having so much inflammation. It also, because it's not binding to the glucocorticoid receptor, it's not giving that feedback that tells the body to stop producing the cortisol. So you're still having more produced. And then with that corticotropin releasing hormone or still being present, there's also an increase in norepinephrine. And also there's an upregulation of glutamate and NMDA, which are excitatory. So the amygdala is the part of the brain. It's sometimes referred as a primitive part of the brain. It isn't really a thinking part. It's more of a feeling part. It gets scared and it has a stress response to that. So the glutamate and the NMDA activate in the amygdala, which then can lead to more pain sensation in the tissues. And it also kind of hyperpolarizes it to where your calming part of the brain, or the thinking part of the brain, the prefrontal cortex, is not able to calm the amygdala down. So it all kind of spirals, and then you have more stress because the amygdala is being activated and it's causing that fear sensation. So this slide is basically showing you the same thing, but I think it's a little bit easier to see here than it is on that previous slide. So again, I'm going to try to bring the mouse forward. So we're going to have this stressor that comes in, and this can be anything that triggers a sense of of stress, of fear, basically. Now, in a healthy person, they're going to have an adaptive response, which then lets them have rapid return to baseline and recovery. In someone that is not adapting well or has a maladaptive response, oftentimes you'll have a fear, and even though it's not originated by something that is worth being that fearful of, you will tie it to, you'll try to find something that it does. Like people start, they call it rumination. They'll start trying to find out, why do I feel this way? Oh, it must be because, and then they start worrying themselves over things and start worrying about what's going to happen. That just causes the cycle to continue. The HPA axis, the hypothalamus pituitary adrenal axis, is activated. So then there's more cortisol that's produced. Again, the cortisol leads to inflammation, which leads to pain and depression. And again, as we learned before, it disrupts sleep. So all of this sets you up, and you can see it, they kind of feed on each other. And all of this can, in and of itself, become a stressor. And then that stressor can start the cycle again. So this is how people end up in these chronic situations. I did want to mention one thing about TMD and bruxism. So bruxism, especially nocturnal bruxism, is now considered not to be a habit. It's not something that the patient can break on their own. It's actually a sleep movement disorder. So we will give occlusal orthotics to help to distribute forces more evenly. So it protects the teeth, it protects the joint, and all of that is good. But don't let the patient think that it's going to make them not grind their teeth anymore, because they will. They just will hopefully not be damaging themselves at the same time. I also wanted to point out that sometimes antidepressants can increase bruxism. Patients will hear that and they will tell you that. But what I want you to be able to tell them is that the risk of depression or anxiety, those risks outweigh the risks of bruxism in most cases. Now, we can talk to their physician and see if there's a different medication that might be just as efficacious, but not cause them the same symptoms. I normally don't like to treat one side effect of a medication with another one, but if we needed to for severe cases, Buspar is something that can help with bruxism. So that's something to keep in mind. But also keep in mind with bruxism that I like to screen them for sleep apnea before doing a type of oral appliance for just TMD, because depending on the severity of the obstructive sleep apnea, if there is obstructive sleep apnea, you may want to provide a different type of device, such as a mandibular advancement device, if that's acceptable for the patient, or depending on the severity, they may need to go through other procedures that would then change what you would need to provide for them. So it's always best to gather all the information before making a decision. With daytime clenching and bruxism, now that is something that they can work on their own to help to break a habit. We often teach patients different stretching exercises just to increase blood flow to the muscles, which helps to reduce pain. Thermal therapy also increases blood flow. We also teach them to check in with themselves every 15 minutes or 30 times a day, however it's most accessible for the patient, however they think they're going to do it, to check in to make sure they're not clenching. And if they find themselves clenching, then to do a little release and then go about their day. And the more they check in, the more they'll be aware of it and the less they'll be holding that clenching. I also encourage, especially the anxious patients, to try more diaphragmatic breathing. By that, I mean to breathe from the diaphragm, from the belly. And that breathing is more, it actually helps to balance the autonomic system in a way that shallow breathing does not. Shallow breathing can lead to more hyperventilation, which can actually make the symptoms worse. If they are getting nice full breath, it calms them, and it helps to keep the blood oxygenated, which actually helps them in the long run as well. Exercise is also very beneficial for any of these disorders. For a pain patient, for a sleep patient, or for a anxious or depressed person, exercise can be very beneficial. I will mention, I believe it might be on the next slide, that you don't want to exercise right before bedtime if you're somebody that has trouble going to sleep, because you'll be energized and it'll be harder to fall asleep at that time. Now, I've heard Dr. Paul Durham speak at several times about nutrition and its effects on the body's overall health. That would be a whole nother topic, and I don't really have time to tell you all that I've learned from him, but the main things are that if you're feeding your body properly, you're also feeding the gut biome properly, and then that's able to help better with inflammation, as well as, according to Dr. Durham, there's been some research that shows that GABA can be produced in the gut by the bacteria, which can then help to calm other nerves and throughout your body. So that is something that is easily done, is to just help them focus on whole foods and good nutrition. So improving sleep hygiene, and by sleep hygiene, just how are we going to try to set up for a good night's sleep? You want to set a good wake time and bedtime and wake time, even on the weekends. Try to keep it stable so your body knows what to expect. Avoid reading for excessive times in bed, watching TV in bed, things like that, so that your body knows that when you go to lay down that it's bedtime. Avoid naps, except if you're working shifts and that's what you have to do. You want to avoid a lot of food, caffeine, alcohol right before bed. Exercising earlier in the day is good. Something relaxing before bedtime, like a nice warm bath or something like that, is good. If you're having trouble falling asleep, try not to look at the clock. If you're worried about something, try to make notes about it so that you can not have to try to remember it for the morning. You can have it written down, you know it's going to be there, and then you're able to go to sleep. If they're hungry, let them eat a small, light snack before bed. Main things that, again, I want to accentuate are that I'm not asking you to make a diagnosis about a sleep disorder or a mood disorder. I'm just suggesting that before trying to pinpoint what the pain or treat pain just on its own, it's oftentimes affected by other things going on in the patient as well. If we don't look at the whole patient, then it's very hard to help the whole patient. And so you may need to refer for a sleep study or refer for further mental health evaluation. And again, this little three-legged stool, basically sleep, mood, and pain are the three legs of the stool, and if one of them is off balance, the whole thing tends to be affected. And those neurotransmitters, the neuropeptides and everything are what kind of tie it together and link those. I'd be happy to answer any questions. I think Dr. Brady's been looking through them for us.
Awesome. Great job, Mary Charles. Thank you.
Thank you.
So actually a common question that we had is there any recommendations you can make about medications, pharmaceuticals for patients where you want to avoid opioids? They've maybe had an opioid problem in the past. What would you recommend?
I actually do not prescribe any opioids for my patients. Oftentimes, if there's an acute flare-up of temporomandibular joint disorders, first what I want to find out is it more a muscular pain? Is it more of a joint pain? And we'll do that by palpating the different muscles. I'll start on the trapezius and the sternocleidomastoid and work my way up. We also palpate the joint itself and load the joint. If it tends to be more of the joint itself, then I'm going to try, usually depending on the severity of the pain, we may use a Medrol dose pack, or we may use, I like naproxen, 500 milligrams twice a day for 3 weeks. I tell them to take it for 3 weeks because it's going to help with the inflammation as well as the pain. And then, of course, if there's muscles, then you would incorporate those exercises that I mentioned briefly, and also have them do those exercises. And if you need to prescribe a muscle relaxer, then that's beneficial at that point as well.
Awesome. All right. And one question that came up is whether or not you know if dentists can write a prescription for Buspar.
I would say that if you don't feel comfortable writing it, then I wouldn't. I feel like if you feel like you've had adequate training and you know the side effects and you know what interactions there are going to be with other medications and you feel comfortable with it, then I'm not sure if there are different state regulations on that or not, so I'm probably not the best person to ask. But I would just say probably if it's in your comfort zone and it's legal in your state, then I would think it would be appropriate.
Yeah, I was thinking the same thing. I didn't know the legal ramifications, but it's kind of the same thing I say even with stuff like muscle relaxers. If you understand it, you're comfortable doing it, but if you're not, don't. And you know, there's another question that came up that I know I've heard a lot about on the news, and I don't know if we know an answer to, but we're talking a lot about NSAIDs and whether or not there's actually any contraindications to that right now because of how it interferes with patients potentially exposed to COVID-19.
You know, that is a good point, and it's not something that I have enough information on. I would be happy to try to look into it if you want to email me, and I can look into it. But I would say that is something to consider at this point in time. I would agree with that.
Awesome. All right. And so a couple of questions that came up because you talked about daytime parafunction. As to whether or not you recommend daytime oral appliance therapy. I know you talked about exercises and behavior modification and all of that, but several people wanted to know if you recommend daytime appliance therapy.
Well, for me, I try not to make blanket statements because as we've talked about, each patient is an individual. I would say that I don't like that a daytime appliance to be a long-term fix. I like over the length of time, I like patients to be able to be independent of it, to be able to do their exercises, to be able to break the habits. If somebody's really having difficulty finding a comfortable place to rest and they're in a lot of pain and it's an acute injury, then I would say that for an acute injury, I would consider that. But as I said, it's hard to make blanket statements.
Exactly. And yeah, because this next question will also probably have the same answer because people are asking what appliance design you use. And my guess is you're going to say probably more than one.
That's true too. So there are several different options. I would say that probably the majority of the time it would be a flat plane with anterior guidance, smooth, hard acrylic, full arch coverage. That's probably a safe one for most patients. I know that a lot of people like to use anterior only pressure, even with full coverage. For a lot of the patients that make it to me, and I see a different population than the general dentist does, a lot of the patients that make it to me have a lot of inflammation in the joint capsule, and that could tend to be aggravated by anterior only pressure. So, but in some cases that may be an option. And then of course in the sleep patients and patients that we're worried about sleep disorders that are maybe mild to moderate obstructive sleep apnea, I would do a herp style appliance most often for those.
Good. Well, you got the next question, so that's awesome because that was, yeah, what you used for OSA. So question about whether or not you have recommended or tried to use any CBD products for your pain patients.
You know, I don't discourage it. And patients have asked me about it. What I do say to my patients is that I don't feel like I have enough information on each company to be able to make a recommendation of which one to use or the amount to use. So but I will tell them that I have heard of patients where it is beneficial, but I tend to not make recommendations for it. I would tend to have them, to not discourage them, but to have them look at also, you would want to make sure that it's not going to interfere with other medications, because there are some studies that show that it can affect the uptake or the half-life of some medications.
Awesome. All right. Quick question about what muscle relaxer you use. Is it Flexeril, methocarbamol? Do you have one that you like better than others?
I tend to use Flexeril a lot because it helps with the pain as well as the, instead of just relaxing muscles, it's kind of helping with that pain level as well. So I feel like that's helpful just because it's related to amitriptyline. So it can help with pain as well. I'm careful with it with, especially elderly patients, just because since it is related to amitriptyline, there is a risk factor there.
Gotcha. All right. A bunch of people are asking about Epworth, and I'll tell you the easiest way to answer all those questions. If you just Google an Epworth sleepiness scale, you'll literally be able to get the tests and bazillion different websites on the internet. And if you just look at it, it'll be pretty self-explanatory about how it's scored and how you get the total value. That one should be pretty easy to answer. Question about coordination of care, because you talked a little bit about different practitioners. And for your patients who have chronic pain, who coordinates that care? Do you think that a dentist does that, or should we actually have them go see a pain specialist?
Well, it kind of, again, that would depend on your comfort level. For my practice, since they're coming to me for that pain, I will tend to make those contacts, make those referrals for them. And then I always keep my referrals in the loop with any changes to medications that I make and things like that. But as far as the general dentist, if you don't feel comfortable with those referral patterns, it's always safe to refer back to their primary care physician and let them know your concerns if that's where you feel more comfortable, and let it go from there.
Cool. All right. And the next one, I was actually surprised it hasn't come up yet. So I finally scrolled far enough to get, how do you feel about Botox for your TMD patients?
Well, so I actually have a few patients that we use Botox for. It's not my first line by any means. I feel like a lot of patients can get well without needing Botox. And there, of course, are some risks with Botox. There are some studies that show that because form follows function, if you decrease the muscle mass, then you can decrease bone density. That's going to be, of course, affected by the amount of units that you're using and things like that. But oftentimes, if we can get the patient healthy without needing Botox, then that's ideal. Sometimes we can do trigger point injections, which are just simple lidocaine injected into a taut band of the muscle, and that can relieve the symptoms without needing Botox. But Botox can be effective in those patients that are refractory to other care.
Awesome. All right. And last one, Mary Charles. Are you using any cone beam, CBCT at all in your diagnosis for your joint patients?
Oh, yes. If I feel like there is if I feel like they're a joint pain patient or a TMD patient, we have a CBCT in office that we can acquire images. I will also, depending on the concerns that I have for that patient, we can also refer out for MRIs if needed.
Awesome. All right. Well, Mary Charles, thank you so much. Lots and lots of stuff in the chat box that you can't see, saying great job, fabulous presentation. By the way, Henry was online, so you know, since you couldn't see the participants, I figured you'd probably want to know that. I really, really appreciate it. And for the folks that are listening, you know, since there's obviously lots and lots of questions about this, if you are curious about treating patients, whether it's simple occlusal muscle disorder, it's more TMD complex, you know, there's several great places to get education. And Mary Charles mentioned LSU. I highly recommend Henry's orofacial pain continuum. I did it when it was back at the University of Florida, and he knows I forgive him for being at LSU. I still love him, but still a great program. And then of course, you know, coming through the essentials, our TMD course at Pankey and our sleep course at Pankey are all great places to get more information.